everyone. Thank you for joining our session. We are very blessed today to have Mickey Tapathi with us, someone who is well known as a leader of ONC and a guy who I feel like every time I walk around, someone's telling me, I just talked to Mickey, so I feel like there must be three of him who roam the United States of America. The other thing I will say about Mickey is that while he's been working on very complex problems at HHS, he actually began his career, if I've got it right, at the Center for Naval Analysis. So he really started his life dealing with very complex problems, and he hasn't let up since in the few decades that have followed. Mickey, if there's anything I missed out from that introduction, do you want to share?
No, I did start in the Pentagon even before the Center for Naval Analyses. I started working in the Air Force Controller's office and then the Secretary of Defense's office. So yes, lots of complexity there. I think I
Pentagon, HHS,
to gravitate toward it.
Yeah, exactly. Not small tents. Okay.
What makes it fun?
No. So we're here to talk about TEFCA to begin with and RCE. You know, a lot of provider friends of mine and I have had hair on fire around nurses' salaries and how do we get the frontline staffed? And then, by the way, how do we make payroll? So meanwhile, like big things in healthcare have been happening somewhere else. So can you talk about what TEFCA is? Can you talk about TEFCA? Can you talk about what RCE is? And maybe a little bit about what they're not?
Okay, sure, yeah. So TEFCA in a nutshell is basically a nationwide network of networks to exchange medical record information among authorized parties, provider organizations, payers, patients, and public health entities. We'd like to, be able to participate in nationwide network. And over time, we'll, sort of figure out once the trust models are in place and once we, all get used to this idea of being able to share medical record information over a secure network, then just like with everything else, you start to figure out, the other ways that you can use it to provide value to the entire healthcare community. And so TEFCA, the federal government is not good at branding. TEFCA stands for the Trusted Exchange Framework and Common Agreement. It comes to us from the 21st Century Cures Act. We did spend a little bit of time thinking, oh, should we go through a branding exercise, name it like Mosaic or Radius or something. And then we just decided, you know what, let's just do this like HBO. It's TEFCA, right? Who remembers what HBO stands for? I mean, I remember, you remember, but anyway, the point is, TEFCA is nationwide network interoperability. What does that mean? I mean, imagine a world where you had a cell phone and it was an AT&T cell phone, but you can only talk to other AT&T cell phone users. And meanwhile, your spouse or your friend is on Verizon, another nationwide network, great network, but you couldn't talk to each other, even though they're both nationwide networks. And then you had Sprint and T-Mobile and all of those on top. That's kind of the problem that we're seeing. And of course, all of us now experience that as a single network, right? If you ask most lay people, they would think, yeah, we have a single cellular network across the country. It's like, well, we really don't. We have multiple cellular networks that are connected by agreement and convention and a little bit of regulation to make sure that they connect with each other. That's what we're talking about with TEFCA, is that we've got a bunch of networks. Some of them are state networks, like in Maryland. Some of them are, nationwide networks. And we want to say, how do we connect them up? And also, how do we fill in gaps that the market isn't able to fill in on its own?
Speaking of which, a number of organizations, I think about 10, just joined your network. Can you talk about some of that? Like, who are they? How many people are impacted by this? I mean, I know it's not happening tomorrow, but can you just kind of fill in some of the details on the progress for the people who just even heard about TEFCA for the first time? Yeah,
so the idea is, going back to the cell phone analogy, who are going to be those networks that want to step forward and say, sure, I'll participate in this thing and, and connect my network with all of the other networks according to a common set of terms and conditions that all of us can agree to, and that it's, that's transparent. So everyone understands the rules of the road. Everyone signs the same common agreement, so no special deals, with anyone. So that, so if you're a provider in Nome, Alaska or Sarasota, Florida, that other party has signed the same agreement and has agreed to the same rules. 6 organizations have stepped forward to volunteer to become, sort of the first pillars of this network of networks capability, or the first networks. And on February 13th, we had a public announcement spearheaded by Secretary Becerra, where we announced those 6 organizations who have been approved to implement the TEFCA network. And so what they're doing is they implement their technical infrastructure according to a set of open standards. So we, insist on open industry standards, non-proprietary standards that, again, are available to everyone. And they implement that. And then according to the contract, they connect with each other to start sharing information with each other. They've committed to doing that before the end of the calendar year.
Yep.
Of this calendar year. So those organizations, you can see them on our website, are, EPIC, Commonwealth Health Alliance, No2, Kanza, Health Gorilla, missing one.
Sorry, I didn't mean to make this
the Health Exchange. The Health Exchange. That's
I didn't mean to make this a quiz. So how many, do we have any sense of the volume and the impact of this, just to put this into perspective?
I mean, those networks, themselves, if you just counted up, how many hospitals, for example, are covered by EPIC and the eHealth Exchange and the Commonwealth Health Alliance today. If you just took those three, you would basically say, wow, that covers, like well over 80% of all the hospitals in the country, just with those three networks.
Which is a big deal and something that, was not, I think, anything anyone had a conception of being reality anytime soon, 10 years ago when some of these exchanges at the state level just got off the ground.
Yeah. And so you've got these nationwide networks that already exist. And then, state level networks and others will join either, as maybe some of them will form QHINs later, or they'll just join under the existing QHINs. The idea is this ought to be a rolling, QHINs, sorry.
I got on the acronym party train and I was going to stop it for a second. Shoot.
These networks, we call them QHINs, Qualified Health Information Networks. But anyway, those
just for those of us on the who are dealing with it every day. Okay, so that's
and the idea is that that's a rolling thing. We'll have more who want to join, and already we've got more applications from other networks who want to join. The whole idea of the model, and this is my last point. And then I'll describe RCE for a second. Is that this ought to be market driven, right? That what we're doing is saying this is a framework for connecting up different networks, and it's a public-private partnership. So the federal government's role here is to say, we can help establish those common rules of the road so that everyone has the comfort that, that the federal government is standing behind it from a policy perspective. Then hopefully that provides a degree of comfort and assurance to everyone that, okay, that we're this isn't a fly-by-night kind of thing. This is something.
And it's always hard when you're an individual provider to worry about benefits and long-term issues that involve portability and people coming in because you're so focused on today's problems.
Absolutely. And so we have a nonprofit partner who is called the RCE. I told you the federal government isn't good at branding. The Recognized Coordinating Entity. They're basically our nonprofit partner who's responsible for the day-to-day operations of the TEFCA network. So ONC, my office, the Department of Health and Human Services, defines kind of the big policy box of here's the playing field. And then our nonprofit partner who are contracted with us are the ones who do the day-to-day operations of the network.
And by the way, just to do and that's contracted through when? Like just to give people a little sense of.
So we have a contract with them that's been in place now for, I think we're in year 4.
Okay.
And so that'll be up for up for rebidding
another long term,
at some time at some time in the near future. I forget what the rules are around that. And then and then we have a bidding process, and then either they'll the Sequoia Project is the organization that does that. Either they will do it or someone else, right?
I just want to give people a sense of the underlying process and stability there as they're thinking about this.
Absolutely. So it's according to federal government rules around procurement and things, right? So you have the idea is that we'll always have that nonprofit partner, but we also need to have competition for that, and so periodically we rebid the contract.
Now, I'm sorry, you dropped a morsel, so I have to grab on it. You said, "Oh, hey, we have other applications." I know you won't want to be specific, but any sense of time frame? Are we saying this calendar year you might be in a position to decide on these topics, or not?
Oh, on other applications?
Yes.
So we've got other organizations who have applied, and they're just going through the process now. And we actually, ONC, we're at somewhat of an arm's length from that process by design, because
got it.
That's why we have our nonprofit partner who can make sure that that those companies have the assurance that their private proprietary information is being held in confidence, and they don't have to worry about is their information going to be subject to FOIA, for example, meaning someone files a Freedom of Information Act and gets competitive information. We want to make sure that those organizations have that protection,
because that does happen. Can we just talk about scope and the information, because we're talking about exchanging information, but we haven't talked about what information is exchanged or what information isn't exchanged. So one of the hot topics now is social determinants of health. And so can you just address whether any of those issues are in that exchange framework as a minimum standard or not, or when you think they may get included, et cetera?
Yeah. So the idea is to share a basic standard payload of information that we refer to as the US CDI, the US Core Data for Interoperability. And for people who feel like they don't know what that is, I would actually assure you that you probably do know what that is. And the reason I say that is, any one of you, I'm sure, Neil, you've been on a patient portal. All of us have been on a patient portal. That information that you see on the patient portal is defined by ONC regulation. And it's called the US CDI. We require that electronic health record vendors support this minimum data set and make that available to patients. And then CMS through Medicare and Medicaid tells providers, you need to make this available to patients. So that basic minimum, data set is what is the basic, sort of medical record information that'll be exchanged over TEFCA via a variety of mechanisms. There's also additional information that payers will make available that supports kind of claims information. But again, that'd be information that that a patient, for example, could get.
So the box has been sort of defined a while ago, and you're gonna run with that.
Well, we want to start with that, and then we can you can have additional data on top. But the beauty of saying let's at least agree on that US CDI is that we know that every electronic health record vendor supports that. Every provider in the country supports it. I think you talked about you've been involved with CRISP in Maryland. The CRISP network, they support the US CDI. The Apple Health Record, amazingly, the Apple Health Record, what do they base the Apple Health Record on? You guessed it, the US CDI. Why do they do that? Because they know that government regulation requires it. So
it's some basic like element in like a hydrogen element in science. You sort of have grasp that and you're like, we're gonna run with that. I get it.
It's like saying I'm gonna this is the periodic table, or it's just the noble gases. We're gonna exchange the noble gases.
Sorry,
I know
I'm dragging us down a super nerd wormhole here. I can just feel it. So I'm gonna pull up a little.
So let me just address the social determinants of health for a second, because one of the things you had mentioned was social determinants of health. So the US CDI actually supports more and more social determinants of health data elements. So when we came into, when this administration came in, we added 4 social determinants of health data categories into that US CDI. And so the idea is that US CDI
that itself, the underlying dynamic will evolve over time, and
so you'll say yes, food security, transportation security. Those are things that should be included in that basic information that's shared. What we haven't done yet, and this will be a part of the growth of TEFCA, is that it's really for HIPAA regulated entities and patients to be able to participate in. As well, you could have providers who are not HIPAA regulated entities, but what we didn't do is right now, you don't have the accommodation for community-based organizations, for example, and others who aren't covered by HIPAA, because that's when you get into really complex issues related to consent, for example. Really critical issue that right now it's based on the idea that there are consent, sort of models, or the HIPAA covers the ways that these entities can exchange information in doing so in a way that doesn't require explicit consent from a patient in the same way that happens today.
Yeah, no, and the other thing is, right, some of those organizations are not even going to be electronic, right? So how do you then get all that stuff, properly in electronic format to even share? And then there's the issue of errors flying around the exchange because you got a paper-based system. No, I think there's multiple good points there. So if about 80% of the country is potentially covered by the end of this year, do you feel like we're at the tipping point where like everyone's going to want to kind of throw their bags on the plane, so to speak?
Yeah, and let me just clarify one thing. So those networks cover 80%, but they do, each one of those participants does have to agree to participate in TEFCA.
Yeah.
So that's just one of the things, so it won't be, even though those networks go live at the end of the calendar year, it doesn't mean that all of their participants
everybody's in.
But it's
but at the same time, once the highway's built, it makes a whole lot of sense to drive on it if you need to get
and those networks are joining because they have a strong sense that their participants want them to join, right? And so anyway, I just wanted to make sure everyone understands.
That's
it's not, December 31st, 2023. Mickey Tripathi said 80% of hospitals connected.
Sorry. No, I'm just saying you built the highway for 80%, or you built the network. It doesn't mean everyone's actually clicked their phone and agreed to join that network, right? But at the same time, at least as a former provider leader, I don't know why you wouldn't.
Right.
You know,
Absolutely.
It
And
just,
will that provide a tipping point? I think absolutely. I think that that's what that is going to do. That when you see those major
yep,
networks connected up, prior to joining the federal government 2 years ago, I was in the private sector for 20 years in health IT,
yep,
doing a bunch of things, helping to build health information exchanges, operating them. And one of the things that, that was always frustrating was that, we didn't have anything to point to. So you can build your local network.
yeah,
If you want to connect with the network in the 4 states adjacent to you, each one of those is like, well, geez, I've got to negotiate this separately. I have to connect to them and then connect to them and then connect to them. If I knew that there is just this nationwide network backed in some way by the federal government that I could just build to connect to them once, and then I'm connected to everyone else, that would have just been hugely valuable to me. And that's,
and you're actually in Washington, D.C. right now, which is literally like not officially a state, but functionally a state that's in the middle of 2 other states where people
Yep.
fly across all the time. I mean, you may
Right.
live in one and get primary care in another and specialty care in the 3rd state. I know because I live there too. And so those state boundaries are in fact functionally useless for actually the delivery of healthcare.
Yep.
From a patient point of view, you're like, I'm just, seeing my physician when I stop by my office. It's like literally that
Right.
simple.
And right now there's just a lot of market confusion because there are multiple networks. So even,
Yeah.
DC, Maryland, I mean, you could have states who feel like, well, I'd like to connect up to a network, but should, is it Commonwealth? Is it care quality? Is it eHealth Exchange? Which one should I join? What's different about them? What's the same? Forget it. I don't want to figure that out right now. The idea here is that if we can just establish that TEFCA is the way that everyone will connect with each other, then you've kind of solved that problem and you start to get a little bit of a tipping point because it starts to, sort of be what people then just sort of know is going to be there as the way they connect.
So I know a lot of people who live and breathe this are going to be very excited about what you're talking about. But if you're a board member at a health system, say, or a payer, or you're a chief financial officer at a payer or a health system or some other entity, what should they know about it? I mean, like what do you think is 2 or 3 bullets that like everybody who's got to know about where this topic is and where it's going?
Yep. Yeah, I would say, 2 things. One is that we are establishing this nationwide network so that if you're the CEO of a hospital or you're on the board of a hospital, you don't have to think about this stuff anymore. Like the goal that I have for health IT is that providers and others and patients and others involved in care don't think about health IT anymore. They just know I can connect to this thing and it'll allow me to do the kinds of transactions that I just want to do. Just like when I buy a cell phone, I don't think about the underlying network. I just buy the phone that works for me and I just, it'll work, right? I turn it on and it works. And that's the first thing is that they should know that that's what we're establishing so that they have that back end assurance, just like banks do, that if I connect into the ACH network for the banks, everything will get reconciled and I'll be able to exchange with whoever I want to, and I don't have to think about it anymore. That's the first thing. The second is that digital enablement means that they should focus in their hospital on getting everyone to digital workflows. Stop faxing, stop, paper pushing. Even recently, I was with my mother, she broke her hip and the hospital is on a very good EHR. I know they're connected to a network in the background. I know they are, this is my job, but they're giving us records and saying, here, hand this to the hospital down the street when you go there and have them scan it and upload it, right? That's the work, I think, of a hospital CEO is to say, this is all going to be electronic. We know we're going to be able to exchange it electronically. So let's stop that in our organization.
Yeah, to my friends, and I have many friends who are actually working on how to use natural language processing and artificial intelligence to read and scan documents. It's the innovation in the industry that I wish didn't exist, right? Like, ideally, we're not even trying to figure out how to automatically scan 300-page documents, right? Like it's sort of like solving for crazy.
Yep.
No, this is fantastic. Let me just talk about another issue, just because you're talking about scans and for the folks who worked in physician offices, you're like faxing prior auth documentation or uploading lots of portals. I know CMS has come up with some new standards around prior auth. Is there anything you can kind of share or ideas you can talk about that a little bit?
Yeah, so, a couple of things. I mean, one, we know that prior auth is a big burden on everyone. It's a burden around the circle. It's a burden on providers, it's a burden on payers. Most important for all of us, or it should be most important, it's a huge burden on patients, right? And patients face delays. You have medical abandonment of people saying, I give up. I'm going to stop asking, I'll go, or I just won't get the care because I can't get, this process to work. And we have no visibility and no transparency into it because there's such variation in the ways that prior auth is approached. So CMS has their draft rule out. We welcome industry feedback. We work really closely with CMS. We also are thinking about health IT and the health IT piece of that to say that, can we have certification in EHR systems that will support prior auth? But we need to work very closely with CMS, right? You don't want to have certification of an EHR system that isn't aligned with the policies. Yep. That, so that's a little bit of the work that, we need to do. And what's critically important for us is getting industry feedback. So, and you've got a draft rule out there right now. We really need industry to provide feedback to CMS on, on what it is they want to see in the prior auth rule. And if they've got issues with it, let us know. Let us know about the standards. Let us know about, what's going to work, what's not going to work, and let us know about what technology enablement they think needs to happen in order for, us to get this, again, yep. This is one of those things that we'll know will have succeeded when people don't think about prior auth anymore.
Yeah, I will say two things. One is, there's some efforts out there. This is just information for the audience. There's some efforts out there at the state level just to like ban the process, which is kind of like bringing a sledgehammer to the situation. And then I have to say, my phone's blown up, actually, speaking of phones, with a doctor who used ChatGPT to like respond to an insurance company. And so if we're trying to get ChatGPT answers, like that suggests we're down the wrong path a little bit. That's just my 2 cents. Okay. Mickey, you've been awesome. This has been a lovely discussion, sir. And I learned a lot, and I bet a few other people have too.
Great. Thanks. And thanks for the opportunity, Neil.
Thank you, sir.